Our next session is called Applying AI Technologies in Healthcare, and it'll be moderated by Bill Simpson. If I could have the panelists come up and take their seat on our nice green sofas and relax and settle in. I'm going to have the pleasure of introducing Bill. Bill is the Medical Sciences Liaison at WinterLight Labs, where he oversees academic and industry partnerships and helps lead clinical research and development in WinterLight's cognitive assessment. Bill has an extensive background in psychiatry, mental health, and clinical data analytics. And prior to joining WinterLight, Bill was the lead of the data scientist at Memotex, another health tech startup here in Toronto. His PhD at McMaster University, Bill studied effects of sleep, inflammation, and circadian rhythm disruptions on risk for postpartum depression. And prior to that, he was a research associate at McMaster. I look forward to your introduction of the panel and a great dialogue on applying AI technologies in healthcare. Bill.
Thank you, David, for that warm introduction. And thank you, everyone here, for inviting us and for getting us to moderate this interesting panel. I think what I'd like to do is, the topic of what we're going to discuss today is really about the practical learnings that we've had from implementing AI solutions in healthcare. So we're going to hear a little bit from each of the panel members on what their solution is, and then we'll sort of get into an open discussion. And I think I just want to perhaps start off by saying I really did like the movie analogy from the previous panel. So I think I'll extend that and kind of answer a question that was posed. And what would I tell to somebody who had no background in AI but wanted to know more about it? What should the one thing be that they do? And I would say, and it's relevant to this, would be to watch the documentary AlphaGo. So I don't know if anybody has seen it, but it's a fascinating look at the efforts to train an algorithm to beat a human at the game of Go. And part of, I don't want to spoil the whole thing for you, but part of where I think it applies to this is you really start to see the effect that the AI has on the individual from, sort of a more philosophical perspective. And, there were people who were lamenting the victory of the algorithm over the Go champion in the documentary. But as the documentary finishes, you realize that each person who played the AI and lost repeatedly, either as part of the training exercise or as part of the grand competition that ensued, actually took away really positive learnings and became a much better Go player because they had played the AI. So I think there's practical things we can learn from using AI and understanding how we can interface with it, and then potentially modifying some of what we do in order to make it better suited to our needs. So I'm not going to blab on about a lot that we do. I'm more interested in hearing what my panelists have to say. So I'm going to introduce each one, and then I'm going to get them to just stay where they are and give us a little bit of background on what they're doing, and then we'll launch into some questions. So first, I'd like to get Phedias Diamandis to give us a brief overview. He's a clinical scientist, laboratory medicine pathology at UHN.
So hi, it's a pleasure to be here. Thanks for the invite, Tekna. So I'm a neuropathologist, and so that means I study the brain, and I use pathology slides as the kind of main tissue how I connect with patients. And really, my task is to look under the microscope and decide what type of disease someone has based on the patterns that I see under the microscope. So I'm a pattern recognition specialist. I went to school for about 15 years to understand what patterns are associated with which diseases. And when I graduated in 2016, which was probably the height of my intelligence, I was really good. I just finished exams, and it was really cool to play these games when you look under the microscope and you can start predicting, is this a male or a female based on the type of tumor that we saw, what hemisphere, stuff that was not on the slide, just understanding, having looked at hundreds and thousands of these cases, what demographics are associated with which patterns. And that's basically what I went to school for. Now, the interesting thing that happened in 2016 was this emergence of this technology known as deep learning that kind of hit the forefront. And you couldn't really log on to Google or Yahoo News or Facebook or Twitter without seeing that deep learning is this amazing computer vision tool for pattern recognition. And so while I was patting myself on the back, I realized that there's this new technology that's perhaps that can do this skill extremely, extremely well. So I decided that I needed to learn how to use this technology and incorporate it into kind of my academic interests. So we recruited a bunch of computer science students from U of T, and really what our program does from the research side is to try to train computers to learn the patterns that they see under the microscope and associate it with the specific clinical information that we have. Why is this really powerful in pathology? Well, pathology is, these are very well annotated images. So these are the kind of firm diagnoses that patients carry with for the rest of their lives. So we have very, very well annotated images. And we have hundreds of thousands, if not millions of images. So we, even just our small research team has now annotated over 1 million images that we can use to train computers. So for deep learning, that's really the amount of data that you need to efficiently use these tools. So pathology was really a very opportunistic field where deep learning and kind of neural networks could really, I think, find a good niche. So that was a nice area to apply these kind of neural networks. Now, what are the challenges of our field? As we learned today, neural nets are kind of a black box. So most of our research is not actually trying to get the computer to make the right call. It's actually trying to understand how it makes decisions. Because in pathology, again, perhaps our strength is very well annotated images, but we can't have computers making errors. So most of the work that my lab focuses on is how can we train computers to tell us when perhaps they're not sure of a diagnosis and kind of and only give a diagnosis when it's very, very accurate. So that's kind of a nutshell of what we do, and I'm sure we'll have opportunities to talk about more once we all go through the other panelists.
Perfect, thank you. I think next, Lianne, if you want to give a summary of what you're working on.
So my name's Lianne. It's nice to meet all of you. I work in everybody's favorite place, the emergency room. I am a full-time clinician at Sick Kids there in the emergency department, and I am here not just representing myself, but we are a team sport. I'm representing nurses and doctors that have been really passionate about the project that we're going to talk about today, and really instrumental in actually bringing it to the forefront for us. So if any of you have been in an emergency department in Toronto in the last little while, you might notice a bit of a problem. What we're seeing are huge volumes. We see over 82,000 children a year in our department. We're seeing a 4% year-on-year growth in our patient population, despite a population growth in pediatrics of about 1.5 or 1.3% in the GTA. This is all with no additional funding, no additional staffing, and no additional space. So like many departments, we struggle with this. And so what we've done is we've employed a technology called Qventus. It is an AI program that takes our data, specifically our CTAS or acuity data, our timestamp data, our population data, and some timestamps about disposition decisions, admission decisions, and initial assessments. And what it helps us to do is really reduce our cognitive load. So as a physician in the emergency department, I can tell you that I know that things will get worse over winter. I can tell you that Boxing Day is rough and only worse really than the Santa Claus parade, which is a real tough day for us in our department. So I can know this and this can exist, but still on a day-to-day basis, we see different surges and peaks in when our patient volumes show up and different surges and peaks in our acuity. And some of these things are predictable, but seasonality for us isn't always based on season. So how are we really going to take all of that information and make our decisions? Because when we're operating at our maximum capacity, we have between 5 to 6 staff physicians, some with teams operating the emergency department, and they're operating asynchronously. So how are we going to bring these people together, manage the people, and manage the patients to try and move patients through in a more nice fashion, how are we going to do it where we can provide good care, safe care, and also make sure that our caregivers are not overburdened on one side versus the other side or with certain types of acuity. So what Qventus helps us do is it takes the data from our EMR and it provides us with a couple of things. So one, a mission control kind of overview where we're able to quickly see how many patients are in the department, at what type of acuity, and how long they've been waiting. We're also able to see, because of its prediction, when we expect how many discharges in the next 60 minutes and how many admissions in the next 60 minutes based on historical and real-time data. We're also able to see the length of stay that's predicted for a dischargeable patient. That's on our mission control. In addition, we have an application that notifies our charge nurses and our lead physicians to say, oh, we're predicting there's going to be a surge in the next couple of hours. Think about redeploying your resources. Or this particular physician team looks like they're overburdened. Is there some way that we can move a physician's assistant, a nurse practitioner, a resident, someone to help them? So what we're talking about here is real-time dynamic movement of our operational team to improve our flow so that we can start to see that movement go through. And this is a collaboration between a lot of different groups with nurse advocates and physician advocates really pushing for removing that cognitive load, that chess game that we play every day, and saying, can we have a machine or a program help support us? So I don't have to rely on myself taking a look at that and making that decision. It will actually notify me to think about this in a timely fashion. And so that's what we're doing in our department. We're really excited about it. There's certainly, I'm happy to talk about the issues and challenges with it as well, but I think that it's a really neat way to approach a big piece of clinical care that isn't actually physically, clinically caring for a patient, but makes such a difference for every patient in our department and their experience, which is really what it all comes down to.
Great, thank you, Lianne. Maybe Yin can give us a background on what he's working on too.
So my name is Yin Aphinyanaphongs. I'm a physician scientist. I've been doing machine learning for about 18 years now. So when I was going through graduate school and a little bit after, I kept on sort of writing papers about doing clinical tasks and doing machine learning and getting really excited about those papers. And after a while, I started to notice that there were a lot of papers that were written, but very few things actually going into clinical practice. And so I thought to myself, well, why is this, right? And as a scientist, when you start to see gaps like that, you start to ask yourself questions about, well, why is translation so hard, right? And so I sort of, talked to my leadership and sold them on this vision of, there's a gap here, and I think I have some ideas about how to close this gap. And so, sort of with their blessing and their vision as well, we're able to put together sort of an internal team of data scientists and engineers who are very, very focused on how to translate models into clinical practice. And I don't mean just building the models. I also mean implementing, evaluating some of the issues with education and buy-in we've tackled already, and actual evaluation, downstream after these models go into clinical practice to see whether they have the intended effects. We're an academic and operational hybrid, which is super important because it allows us to operationally, drive sort of value, At the same time, we can answer some of the core scientific questions that are unanswered, and how these models are used in clinical practice. Also, on the very end, we have some work with the physicians themselves, and how they react to these models. There is this onus of sort of an algorithmic bias, When people see errors in computer algorithms, they're very quick to dismiss the algorithm and say that it's not working, And so we're super careful about how we sort of quote unquote market these, how we communicate to physicians, how we teach them in a way that they understand what's going on. When they see errors, they don't jump to their own conclusions about what's going on, and that there's a pathway for us to be able to give them feedback on these issues. So for us, it's not just about the model, For us, the model is probably like 10, 15% of actually doing the task. It's all the things downstream, Working with the clinicians, working with the people, trying to get buy-in, having them use the results consistently, human-computer interaction and interfaces through our EHR. And that's the part where, we're really focused on trying to get that translational piece working and making sure that the science behind the model aligns with the actual clinical goals.
Great, thank you, Ian. And Teo, you're the last one, but not least.
Thank you. My name is Teodor Grantcharov. I'm a general surgeon at St. Michael Hospital, and I'm the director of the International Center for Surgical Safety at St. Michael's. I remember I spoke here at Techna a couple of years ago, shared a little bit our idea to create a platform to capture data from everything that happens in a surgical operating theater. And it's exciting to be here a couple of years or a few years later and to share that we're still around. I remember a few years ago when I presented the idea to our hospital. Initially, the response was, this will never take off. There will be a lot of resistance from surgeons and nurses and risk management from the hospital. And then we kept knocking on the door, and finally the hospital said, okay, we won't help you. We won't help you, but we won't stop you. In 2014, we implemented the platform. We started capturing data. And now our platform is in 50 centers around the world. So I started my career 20 years ago. I remember at that point what I found very fascinating is the ability to measure the skill of the operating surgeon. And at that point, that was very novel. Nobody believed that we're different. Everybody assumed that once we graduate, we're all the same and we provide the same quality of care. The reality is that's not always what really happens. We have good days and bad days. We work with a team that's very highly functional, and some days with a different team. And our performance varies tremendously. And our outcomes vary. So we wanted to understand what is this relationship between performance of the team, performance of the devices we use, distractions, disruptions, environmental factors. What are the temporal relationships between all these factors and how they translate into clinical care, into patient outcomes, into clinical costs. We started initially with capturing data through video and very quickly understood that the data becomes overwhelming. And we need a good, robust methodologies that help us process this enormous amount of data and make sense of it. So that's how we understood that we can't do it alone. In surgery, we've worked for many years within our profession. We have been fairly poor at bringing together a multidisciplinary team, and that's what we decided to do on our team. We involved computer scientists and data scientists and experts with various backgrounds from art and design, expertise in AI methodologies, and that helped us within a short time to capture data, process this data, and when we bring in our database together with patient factors, disease factors, post-operative management factors, to really understand what are the things that we can modify in our work in order to improve patient outcomes and reduce healthcare costs. That's the stage we are right now. We can currently help the next patient, not the patient who is currently in the room, but as our ability to build these algorithms, our ability to deploy modern AI methodologies in our practice, we hope that in the very near future, we will be able to help the patient who is currently in the room with a concept we call AI-guided surgery. So I'm happy to have a discussion in the next few minutes around challenges and opportunities and how we can work together as a team to make healthcare safer and more efficient.
Thank you, everyone. Great overview of the work that you're doing. I think what I want to start off by asking is I think something that everybody might be interested in that can you give us a little bit of insight in the projects that you've worked on? Like, what is that feedback from physicians, and even if you have some insight into what patients are thinking as well with these technologies? Because, you know, I think we think a little bit about how people might be resistant to allowing an automated technology like AI into what has traditionally been a 100% human process. There's some ego to be guided, or there's some ego to be dodged potentially, but I think that there might be a misconception about how people perceive these things, and so I want to get some sense from you guys, you know, being on the ground floor and implementing these things, what you think about that. So
my experience is that the errors that we see that our computer algorithms make are very, very different than the errors that humans make. And so I think this idea that one is better than the other is actually false, or one is perfect and one is not, is the wrong way to look at it. I think when you kind of make that Venn diagram and you say what computers are errors, what errors are computers making because of insufficient data, as we learned, or changes in variables that are not yet incorporated into the system, they're very, very different than the errors that humans make because they are tired. Someone walks into their office while they're looking at a slide, typographic errors. So I think I think the two together is a powerful formula, and I think patients. We've done kind of a survey to see what patients want, and I think the patient is their view is very simple, right? They want the best possible care, the least amount of errors, and if computers and AI can help reduce errors in diagnostic interpretation, I think it seems that patients are very open to that.
So I would say in my example, it's different, and it's an important difference, right? We're not providing clinical care through AI, but we are providing operational flow management with the assistance of AI. So I want to make that really clear and that delineation really clear, because I think it's important. I think that what our program in our use case provides is a decrease in that cognitive load of a part of a job of a lead physician or a charge nurse that is not their principal job, firstly. Secondly, is always evolving and changing due to a variety of factors that we can't possibly ingest simultaneously. And I think that the goal for us is to make people's jobs easier by having this assistance as opposed to adding a burden. So where we've seen resistance is in physicians and nurses that feel that the program is giving them additional work. So either they weren't looking at all at cognitive load and they weren't considering where to move patients at all, they were just focusing on their clinical medicine, so that was never part of their practice. Or it's a hidden part that they're not really acknowledging that they're having to do, and this isn't actually a benefit to them. For us with patients, we have our mission controls on big screens in the emergency department, and so while we haven't talked to the patients about it, they can see the big screens, they can see the bubbles kind of moving around, and they have asked about what is going on. Because of that interest, what we're actually doing is we're adding another factor that we're going to be projecting probably in the waiting room, which is initial provider time. And we're hoping at the 90th percentile that will give the waiting room a bit of information saying, this is realistically how long you're looking at worst case scenario, and kind of providing and advocating for our patients and families to know why we're using this and what value add it brings to their care.
So this issue of resistance and buy-in and getting people to believe, right, and not question. So I sort of have a three-pronged answer to this because we thought a lot about up front. So we have a 2-month mortality model that we've actually deployed in our hospital. And what it does is it says, hey, look, this patient looks like they're going to die in the next 2 months with an 80% positive predictive value, right, with an 80% accuracy. And what the team does with that is it just gives them a moment to take a moment and pause and think about the things that they're going to do, right, for this patient and whether those align with the goals of care of the patient themselves. So you can imagine in that really sort of risky situation there, right, you'd want to have a framework to help the physicians be confident and understand that this is working. So there are 3 things that we do, right? The first thing is I drive confidence through the data. Right, so we show them experiments. We show exactly like in randomized controlled trials for drug studies. Right, we show that there's this intervention. It's a machine learning model, and we show that the outcomes are consistent. So we do that both retrospectively internally and prospectively. So we take the model, we run it prospectively, and we say, look, what I'm telling you is true. Right, 80% of these patients die in the next 2 months. So that's one, is to drive it through data. The second is to drive a buy-in through experience. So very early on, we start to actually admit these patients every day to the clinicians so they can see what the models are actually classifying and what these patients look like, right? And this makes them confident that the model is indeed doing what they expect it to do, right? And so it's not throwing off these really crazy classifications or other things. And sometimes it does, right? And that leads into the third thing that we help give them confidence is about infrastructure. And so we show them tools. We have monitoring tools in the background that monitor the models, how they run, that they're running effectively, that the variables that are input are not changing. And so this gives them confidence that there's not going to be all of a sudden be an output that they can't understand because we're going to get to it first, right? And we have ways of shutting down the algorithms and having them not send out notifications when we identify errors in the actual processing pipeline. So it's through data, experience, and infrastructure that we really are able to get a lot of buy-in and confidence in these models when we deploy them.
So I agree, buy-in is key. Getting buy-in from surgeons and surgical teams is not easy. It's a challenging task just because surgery is a fairly conservative specialty. We have been doing things the way they've been done for hundreds of years. We feel, generally our profession feels resistance to introducing new modern technologies and methodologies. And we had to address that through evidence and through very clear definitions and openness and transparency and accountability around what we do and how we do it. And one of the fundamental questions here is that probably differentiates AI in healthcare than AI in traditional tech areas is that it has to be based on evidence. It has to be based on the principle that we're not just capturing data for data's sake and we're not creating technology for technology's sake. In order for this to be to achieve the buy-in we want to see, it has to provide value. Value to clinicians, value to patients, value to hospital administration. And we won't be able to do that without clear and very solid evidence that's based on sound research methodologies. So that's how we approached it. We started with a question. What do we want to show? What do we want to influence? Is it number of errors in the operating room? Is it the performance of the surgeon or the surgical team? Is it the patient outcomes? And then, starting from there, we had to find out what are the data points that we need to capture in order to answer these questions. And then we had to go through a very detailed methodology, how we add data points, we measure them, we study them, and then keep those of them which make sense to us. And finally, we have reached a point where it is accepted by our teams, but still a long way to go to be universally accepted in the surgical profession. But as we continue to generate evidence on the impact on patient outcomes, I think we will be able to achieve the vision where AI-guided surgery will make surgery safer and healthcare cheaper.
Thanks very much. I think the general theme that we're hearing is a lot about let's take the tasks that we know machines can do reliably and just get machines to do them, and then leave the human-based tasks to the humans, particularly around, perhaps coordination of care or the emotional side of care. And I'm not an MD, and I'm the only non-MD up here, so I do feel a little bit, outclassed. But perhaps you guys could give some insight in how you think the role of the physician will shift in sort of a 21st century and beyond, where these technologies become more and more commonplace and less simply sort of investigational or piloting is the way we're doing it now, but then eventually become integrated. Like, what do you think the ultimate role of the physician will be and what that looks like? Anybody can start. We don't have to go in line.
So I think it's really what you said. I think it's really trying to optimize where these tools can be most cost efficient and effective in improving workflow. So I know for us, there are certain tumor types that computers can actually recognize quite well and give accurate diagnoses. And admittedly, those are the types of specimens that take me the least amount of time. So it's kind of a catch-22. The cases that are very difficult for humans are also difficult for computers because there's very few of them in the world. So we have very few training examples. So I think I think it's still an early time where we really need to optimize where computers are adding value. And it may not be in every single sector of care, but it may be in enough sectors that we can reduce the kind of tasks that we bestow on healthcare providers. Even if we reduce it by 30%, that means that those clinical specialists can do their job 30% better, whether it be counseling patients, explaining to them complex medical diagnoses. So I don't think, even if we don't fully replace what a human can do, I think even if we reduce the amount of work, can really transform care by letting humans do what they do much better.
I think in my future hope and dream, the thing I think for Canada in particular that technology, AI, and I think portability plays into this as well will really improve for us is remote and rural medicine. I trained in Manitoba. I worked a lot in the north. It's a very unique and specific population that has a lot of lack of access when we compare it to somewhere like the GTA. And when we think about things like assistance and decision making, I think about the ability I have at Sick Kids to call my intensivist and call my staff radiologist and get opinions on something and have that support. And I know my friends that are practicing in Whale Cove do not have those same privileges. And so to me, the value in all of this for our country is to really democratize the ability to provide healthcare in a place that should have healthcare wherever you go. I think it allows experts in certain centers to really link and provide information, whether it's through an AI technology or through assistive remote technology, and actually help patients far beyond the reaches of their urban center or their tertiary care. Because to me, that's where the real impact's going to be in the future, and I think it's something that we as Canadians have to address urgently, because that disparity is just growing and growing and growing, and I don't think it's acceptable.
So I'm super optimistic about the use of AI. I think it's going to make actually physician lives a lot better. And specifically, I'll tell you why. So in this mortality model that I've been referring to, if you're a clinician and you look at that patient, you're going to tell me that, oh yeah, I can definitely tell that patient's sick, right? And that they're probably not doing well. And so you may ask yourself, well, what's the value add there of telling me something that I know already, right? And it's not actually about, the identification is important, right? Because machines are really good at going through large tracts of data, right? And trying to identify people. But most importantly is the quantification, right? So now I can tell you that this patient has an 80% risk of dying in the next 2 months, right? And now that you have that quantification, you're moving away from this idea of, subjective gestalt, right, about, oh, what I think is going to happen, to something that's more quantitative and more objective, right? And now that you have that objective information, you can drive decisions from that. And even, higher up, you can even drive policy from that, right? Because you have certain certainties about these models sort of being applied. The other thing it does is it takes away some of the variability, right, in training and other things, right? Physicians, and we've seen some evidence, right? Physicians that have been practicing for 30 years are much better at trying to determine who's going to die, right, in the next couple months than a physician that's just out of training, right? And so how do you get everyone all on the same scale, and how do you get to sort of a quote-unquote deterministic system, right, that's sort of very agnostic, and it's just doing the classifications, right, and providing quantitative outcomes. So I think that's where it's going to be great, right? Because no, you're no longer having to work under these, under just the gestalt or the feeling that you have. You can work with some certainty. And the second thing I think it's going to do, in reference to in radiology, I think there are some tasks, that are just take a long time to do. So last year at the RSNA, I think there was a competition for bone age. And so they had a data set that was trying to look at estimating bone age, right, from radiographic images of the hand. And that task, my understanding is that it takes a long time to do because you have to do lots of measurements and do other stuff. And what takes a human about 30 minutes to an hour to do, it takes the computer literally like 5 seconds or under a second. And so there's going to be just a refocus of energy toward things that are sort of more interesting, right, than just trying to measure bone age and measure other things. So I think it's going to be a really, really great story, and we're going to look back on it, wondering why we weren't there sooner.
I think we need to have realistic expectations about AI in healthcare. I think it will be naive to believe that it will solve our problems and it will replace us and automatically reduce error. I think we have to look at AI and AI methodologies as a tool. That will be successful if it's used in the right context or with the right purpose. And it will be a failure if we use it as an isolated solution to all our problems, the problems in education, the problems in quality and safety or efficiency. So I do believe, and I agree with all the other speakers here on the panel, that it has a tremendous potential as a tool to reduce variability. And variability in healthcare is a problem, and it is something that we as professionals need to address. Variability in our performance, variability in our decisions, variability in patient care. And I think if we do that, if we apply healthcare within a clear concept of reducing variability in many different areas, I think we will be able to demonstrate value. But again, in healthcare, unlike many other areas, all the claims around the value need to be based on well-executed research demonstrating it and confirming it. So I think we have a long way to go in order to show the value of AI in healthcare and in surgery. I think it has a tremendous potential, and I think there are some really amazing examples out there. We heard some of them today, which we can build on and continue to develop in a collaborative, multidisciplinary way.
Great, thanks everyone. I think at this time I'd like to stop asking questions and turn it over to the audience, who I'm sure have some questions about the implementation. I think, we've heard a lot of really interesting stories from different sects and from looking at it from an operational point of view or a purely clinical point of view, but I'm interested to see what our audience members might be thinking to ask the panel. So I'm going to move to the podium so I can not be blinded.
The question is for Lianne. I just wanted to know, so when you were talking about the AI that's currently implemented at your hospital, you said the main value it's bringing is reducing cognitive load. And I think there is a tremendous value in that for the team in general, just to help you be able to concentrate and focus and do your job better and more efficiently. But as an innovator who, let's say, is trying to bring a technology into the hospital, I'm interested to know, is this a technology that was developed in-house, or is it something that came externally? And how did they quantify that value to the hospital, let's say from a business side, so that it could actually get implemented and they made the case?
Really, really good question. So it is an external software. It's an external software that has been employed in multiple hospitals in the States. And it was actually a very fortuitous combination of systems, because you're right, the question is where's the value, and where's the value at that C-suite level, the people who actually control the budgets, right? Not me on the ground working in the emergency department. And so what happened with this particular software was there was a donation made to Sick Kids by a family who wanted to prioritize technology innovation. And we were really fortunate that they really want to focus on the emergency department. Granted, we need a lot of work, so I see where that focus comes from. And we are one of the only divisions in Sick Kids that touches many people, right? We're not restricted to a certain patient population. And so I think that innately there's a bit of an appeal there. So we were able to secure the first year of funding through that donation, which allows us time to prove the business case, to be able to continue it forward. Outside of the financial piece, though, I will say that while it started in the emergency department, we have now had meetings with diagnostic imaging, laboratory medicine, and the inpatient wards who all want to be part of this because they see what it's doing for our movement and our staffing, and they want to explore those bottlenecks from the emergency up to admissions, emergency into ultrasound, emergency into x-ray, and say, can we use our data to better manage our people? Because it actually turns out that they're not doing a lot of that active management for mitigation of surges. So outside of the financial side, with this time for exploration, that value add is being seen by other areas of the hospital in an unexpected way for us.
If any of the other panelists have answers to that question, I'd be interested to hear them as well.
So ours was completely in-house because we felt like the conversations that we needed to have with the frontline physicians and the interventions and the care managements and other things that needed to happen had to be intimately connected together, and that we couldn't go off and just sort of, do this and, get physicians to even buy in or to use it unless they were part of that process. And it was really driven by sort of, the priorities of the hospital and understanding that, there are a lot of patients that don't die in the way that they want to, right? Don't have the quality of deaths that they want. And so it's a motivation to, make sure these people have advanced care planning notes and advanced care planning conversations, right? It's not suggesting, anything else besides just saying, hey, here's a number. And as with the physician and provider team, we're going to help you try to figure out, a series of things that should probably happen, right, in that instance. And that's what it does. And it's really reducing this variability of care, right, between what people think will happen, right, versus just a number, right? And it's just like any other lab. You just take it for what it's worth, and if you decide to use it, you can. Otherwise, you don't have to.
Go ahead.
Yeah, I got a couple of comments. The distinction between AI and automation, because we talk about AI, but I mean, really, there's just a huge, amount of opportunity for automation in healthcare. And it's a little bit disturbing that we aren't investing in it. I mean, service industries and robotic process automation, they say there's about a 20% efficiency potential in service-oriented industries. And I think we need a significant investment in automation in healthcare, because if we had 20% more capacity, we would spend that, dramatically changing the experience of our staff and our patients. And we're running out of money, so it's important to automate. My question is, as a comment, my question is to Teodor. You're in an OR. You build this black box thing, which is pretty cool, which I'm really a big fan of. You're using AI to start to understand that information. Maybe the multidisciplinary elements that are going there, because you're in there as a surgeon, but there's an anesthesiologist and there's a nurse and lots of other people in there. So how did the AI kind of shake up the team, or how did the team collaborate in the AI, the box? I'd love to hear that story.
Yeah, that's a great question. We felt, and we knew very early on, that in order for this to see the level of adoption we wanted to see, we needed to provide value to every single team member. And one of the early projects that we embarked on was understanding how our interactions impact our performance. One of the first papers that we created was showing how performance of the nursing team impacts the performance of the surgical team, and how the leadership, communication, and situational awareness of the surgeon impacted the performance of the nursing team. And then we added the anesthesia team. So it became very clear to us that the traditional model, where we invest in the education of the surgeon, is not sufficient. In a day, the same surgeon, a day where he or she works with a high-performance nursing team or high-performance anesthesia team, they can perform extremely well, and in a different day, they'll perform very poorly. So this was very clear evidence that team familiarity, investment in education of team member was critical for the success of this initiative. We wouldn't have been able to study that without capturing large amounts of data that's all on the same platform, where everything is perfectly synchronized, and we can create some evidence around temporal relationship between performance, outcomes, distractions and performance, stress and performance, fatigue and performance, and then how all this relates to clinical outcomes. So this morning I was at an event at one of the hospitals in the GTA where we've been capturing, when we introduced the black box a few months ago, and they looked at the data, and it was pretty amazing to see how this data is used to study failures and to study successes, to look for patterns of adverse events in the operating room, and understand that many of these factors are modifiable. But without evidence, without insight based on real data, we would never have been able to identify these patterns, and we would never been able to impact them. So yes, in order for any initiative in a team environment, in a team sport, to be successful, that it has to provide value to every single team member.
One thing I just want to add as part of this conversation actually is I think, you know, a recurring theme is that, you know, ML and AI and these approaches, even, you know, if you start from the ground up where you don't have the information in front of you and you're just creating a way to aggregate it so you can use it, I mean, that in and of itself is not a particularly sexy application of AI, but I think as the panelists have really described, it's potentially one of the best actual applications for it is providing information that you wouldn't have been able to see otherwise in order to inform decision making. And I know we were talking a little bit at lunch about, you know, there's obviously an impetus to solve a very sexy and interesting problem, but there are a lot of other problems that are sort of at the ground level, some that are related to automation, as David mentioned, that could be solved quickly, relatively simply if we just focused our efforts in that way. So just a tail end of that. Other questions? There's one in the back over there.
So I had a question more relating to, you know, down the line. So the way hospitals work, right? There's reimbursement codes for things. So is AI going to help? You know, sort of, how close are we to actually having a reimbursement code for like an AI algorithm, or is the AI going to be more of a helping to get through more things faster, where the person would be signing off?
It's a good question. Anyone?
So there is a code, and you probably know better than me in radiology. I mean, for breast cancer and for breast mammograms, there is a code for computer-aided detection for doing mammograms, but I don't have a good sense of how that's used, and I'm not a radiologist, so I don't know, you know, how that affects reimbursement if you use the system, if that actually decreases your rate or, you know, whatnot. But so it is somewhere, someone's thought about it, but I don't know if it's, you know, not along the lines of what we're talking about, I think.
This isn't really a machine learning example, but I also teach point-of-care ultrasound in the emergency room, which is a technology that I believe enhances clinical judgment and decision-making for a subset of patients that I see. And we can talk about billing and the existence of, you know, the Canadian healthcare system and all of the ways that it is challenging us. But in my future state, I see an augmented practitioner getting an additional percentage for a specific type of care they provide with verified, evidence-based adjuncts compared to another practitioner that is electing not to. So not that you don't have the access for it, but that you're choosing not to. That would be my personal state. So you get that 10% premium because you've decided to provide these safeguards for your own decision-making based on what's available to you. But that's a future state that is obviously significantly different from our current model.
I think we're starting to see shift in attitude in this area as well. I recently read there was an AI algorithm in ophthalmology that's been approved in the US and already applied for reimbursement purposes. But the model could be, the financial model is used in other areas as well. For example, some of the malpractice insurers in the US provide discount in insurance premiums to surgical teams who have implemented simulation in their work. significant discounts. We're now working with a malpractice insurer in the New York area, where they will do a similar approach for hospitals and surgeons who have implemented the black box technology, because that will help them identify patterns, identify risks before they've resulted in adverse outcomes, and in this way they could mitigate this risk, and that investment will later return. So I think there are many ways creatively to implement these financial models to reduce risk, to improve performance, and reduce variability. And I have no doubt that we will see more and more initiatives to change the way we practice and to change the way we reimburse.
I'll just add one note to that from the point of view of a technology company that's trying to actually build an AI technology that eventually physicians would use and be able to reimburse for. I mean, from a research point of view, I don't think there's a barrier to developing these kind of things, or even from an investigational point of view in the private sector. But at least in Canada, if we can't figure out how to have the system pay for a technology, then there's always going to be a roadblock to implementation. And I agree that varies across jurisdictions and all these other things. But changing the reimbursement structure to allow for these assistive technologies, I think, is a necessary step before we can get a full integration of the work that we're doing.
Yeah, just one last point too. I'm a salaried physician, so I don't know what billing codes are, but I think the challenge that we have in pathology is that there's been a huge explosion of molecular technologies in our field that are considered much more precise in their diagnostic capabilities than kind of traditional tools like H&E staining. Now, the challenge is that an H&E stain can be done for $1 or $2, and some of these more advanced technologies cost $2,000. So how we want to use it is, can we really figure out what is the added value of those very, very expensive and high-tech technologies to the kind of more traditional and cost-effective technologies? And is there areas where we're doing the system a disservice by ordering additional tests? And I think that's how we want to use kind of the data that we're collecting is, can we recommend a de-escalation of specific diagnostic tests where we know that the H&E test or 1 or 2 immunostains are sufficiently accurate enough to always make the correct call. So I think there's a huge cost savings, and I think as we all talked about, the kind of this gestalt, or when do you order the more kind of high-power tests, and when is the kind of clinical exam or cheap test sufficient?
Great. I think we have time for one more, if there is.
Okay, I'll go. I got one question. I mean, on the cost side, I mean, these things should be less expensive to operate than a human. I mean, that's pretty clear. So we should be motivated to adopt them to save. In like Tom's development and AI for radiotherapy treatment planning, goes from a 4-hour activity to a 4-minute activity. That's a huge savings for cancer patients. So the codes that pay for that now in the U.S. model just cost less to do it with an automated method. So that's pretty obvious. People should adopt it. What I was curious about, and get maybe the panel's comments, and some of this comes from Tom's work as well, and your comments around the Go thing, is that humans get better when they work with these machines. And I'm curious about, how does the panel think about your buddy beside you? There was a bunch of implanted chips and stuff in physicians' brains. I don't know if you saw those comments. It's a little bit freaky. It seems expensive and high risk.
Terminator level comments.
But and Phedias and I have talked about fellow.ai because we already have physicians that have fellows that help them out, and the fellows do something, but then the expert with the experience comes in and helps out, and so the sort of hybrid space. And I wanted to kind of get a feel for, how do you feel about that? How the machines could teach you or learn faster, the learning side.
Yeah, so we've talked about this a lot. We think because of the discomfort of having computers make important decisions, we've kind of used AI to kind of generate some of the reporting structures that we take a lot of time to type up. And when we have fellows, it's not a big deal because it happens after hours when we can assign the task to them. But when we don't have fellows, we got to type up these reports ourselves, and we're not very good at it because we rely on them. So I think for those kind of mundane tasks, computers are very good because we've kind of created a generalized structure where we can automate what goes into the report, and then us as physicians can just really focus on fine-tuning the report instead of having to generate it from scratch. So that's been a very effective tool for us.
I would just say that I think that your comments are very true. I think that my hope is that this will improve our clinical capacity. And I think that, at least when we were speaking, we're privileged to be salaried in an academic institution where we have time carved out of our day to think about these considerations and build these things. That's not the majority of healthcare practitioners in this country. And so we have to be reflective of that. And they're not going to use these technologies if they don't see that innate value. And whether that value is demonstrated through changes in billing or whether it's demonstrated through improvement in their clinical care, through patient satisfaction, through however you want to measure that, I think that all those factors have to come together to actually make it valuable. But I see that as a relationship. I don't see it as one or the other.
And I think that was a little bit of a vision behind Watson, right? It was supposed to be like a really smart second-year medical student, right? Or a really smart intern, right? But really maybe not exactly knowing, what they're supposed to do in that situation, right? So I love the idea, right, of having, sort of this backup, right? But I think what needs to happen before you get there is there has to be the evidence, right? There has to be evidence that shows that, the treatment plan that you can generate in 4 minutes is close or as reliable as a treatment plan created in 4 hours. And once you are confident that that's the case, now you can start, checking over your shoulder and being like, hey, what should I do? And then get some confidence. You can learn from that, right? So I think the computers have to prove themselves to be worthy before we can just make them worthy. And I think we need to have good studies and good papers and good research to do that.
Yeah.
I think computers and AI can be worthy and useful, not by replacing us, but as you just mentioned, by assisting us to perform better. And we've seen many examples. For example, we use some of the data that we captured and visualized it in a way that it served as an intervention, as a coaching intervention, as a virtual coach. And through a randomized trial, we were able to show that this approach helped us improve our performance and reduce the number of errors in the operating room with 50%. So I think as we continue to implement these technologies, they will be able to provide this feedback, to provide this level of automation or forcing functions in the operating room that we've seen in many other high-risk industries, and we've seen what they've done to make oil industry, nuclear industry, airline industry much safer.
Great. Well, I think the timer's run to 0, so that's all we've got for this panel. But I want to thank all the panelists for joining me up here today. Everybody, thank you.